The first speaker of this ERN-EuroBloodNet webinar on thrombotic microangiopathies, I will speak today about the thrombotic thrombocytopenic purpura, or TTP, and its ADAMTS13-related pathophysiology. These are my disclosures. This is the outline I have chosen for this talk. First, I will provide you an overview on TMAs and clinical description of TTP. Second, I will recall the historical background for TTP pathophysiology and how we moved from von Willebrand factor to ADAMTS13. And third, I will show why ADAMTS13 is now considered as the cornerstone of TTP pathophysiology. And finally, I will give you some perspective on how ADAMTS13 is important beyond TTP pathophysiology as a definition criteria, a diagnostic and monitoring tool, and also a therapeutic target. TMAs have a global prevalence of 50 to 100 cases per million people per year. TMA is actually a syndrome that associates a microangiopathic hemolytic anemia, a peripheral thrombocytopenia, together with some organ failure of variable severity related to thrombosis of the microvessels. When considering TMAs in the global picture of hematology, they belong to benign hematologic diseases, but interestingly, they are at the border between cellular hematology and hemostasis. The Princeps clinical descriptions of TTP were done in the first half of the 20th century, almost 100 years ago. In 1924, Eli Moscovitch reported the first case of TTP, likely autoimmune, in a female adolescent of 15 years old who presented with fever, cerebral manifestations, anemia, hemorrhage, renal and heart failure, and died in 2 weeks. At autopsy, thrombi were present in arterioles and capillaries of almost all organs. In 1960 and 1978, Upshaw and Schulman respectively described similar cases, likely congenital, in younger children. At this time, the prognosis of TTP was devastating, and anatomopathology of patients' necropsy interestingly revealed that the microthrombi were present in all organs, strongly suggesting that TTP was due to a systemic microthrombotic process. The 90s are a major breakthrough in TTP treatment thanks to Rock and Bell's groups. Indeed, since 1990, empirical plasma therapy by daily plasma exchange, provided they are initiated in emergency and maintained until clinical and hematologic remission, have dramatically been improving TTP prognosis, allowing a 95% survival, although patients almost systematically died before the era of plasma exchange. To better understand TTP pathophysiology, I think it is mandatory to recall the historical background of this story. In other words, how both scientists and physicians have moved on from von Willebrand factor to its specific von Willebrand factor cleaving protease, ADAMTS13. So finally, how did von Willebrand factor become a usual suspect in TTP pathophysiology? First, clinical observations of TTP patients showed that they are likely to miss or have in excess a plasma protein because TTP not only is a systemic disease, but it is also cured by plasma exchange. It sounds reasonable to think that this protease system may be related to von Willebrand factor because, on the one hand, von Willebrand factor is known as a key protein for platelet-mediated clumping, and these adhesion and aggregation processes specifically happen within the microvessels. And we're going to see why in a flow slide. On the other hand, TTP is due to platelet-rich thrombi specifically present within the microvessels. To better understand of this, let's spend a few slides on von Willebrand factor itself. Von Willebrand factor is a large glycoprotein synthesized in two cell compartments, the endothelial cells and the megakaryocytes. Von Willebrand factor is first synthesized as a big monomer of about 2,000 amino acids that contains a signal peptide, a propeptide, and a major subunit. During its maturation process, there is a constitutive secretion of von Willebrand factor, both in the blood and in the subendothelial matrix. Also, some von Willebrand factor is stored within the viral pellet bodies of endothelial cells and in the alpha granules of platelets. The specificity of von Willebrand factor is to be a multimeric protein. If you check von Willebrand factor in plasma, you will never find monomers, but always multimers with a great variety of sizes. The smallest multimer is a dimer, then two dimers associate with disulfide bonds to form a tetramer, and so on. And the biggest von Willebrand factor multimers usually contain 30 to 40 dimers. The multimeric distribution of von Willebrand factor can be visualized using an SGS agarose gel electrophoresis, where von Willebrand factor migrates as a function of its molecular weight. The dimer is the last band at the bottom of the gel, while the larger multimers are located on the opposite, at the top of the gel. Interestingly, when you compare the multimeric distribution of von Willebrand factor extracted from endothelial cells and that of von Willebrand factor present in plasma, you can see that there is a physiological loss of the ultra-large multimers between the cells and the blood. This multimeric structure of von Willebrand factor has a direct consequence on its function, as the longer the multimers are, the bigger the number of von Willebrand factor binding sites of platelets is, and consequently, the higher the hemostatic power of von Willebrand factor is. Something also very specific to von Willebrand factor is its ability to adopt different spatial conformations as the function of the shear rates of blood flow within the vessels. What you can see under either atomic microscopy or video microscopy with fluorescence is a conformational change of von Willebrand factor as a function of the shear stress of blood flow. At low shear rates, von Willebrand factor has a globular folded conformation. In contrast, the higher the shear stress is, the more unfolded von Willebrand factor becomes. At high shear rates, von Willebrand factor is totally unfolded as a long string, which lengths can reach 10 micrometers. The physiologic unfolding of von Willebrand factor by the high shear stress of blood flow present in the microvessel induces a better exposure of von Willebrand factor binding sites to platelets and then enhances von Willebrand factor hemostatic power. In summary, you now understand why von Willebrand factor is a key mediator of platelet adhesion to the subendothelial matrix exposed to blood flow after vascular injury, and also the mediator of platelet aggregation at high shear rates of blood flow. Again, the larger von Willebrand factor multimers are, and the more stretched by the high shear stress physiologically present in the microcirculation they are, the more adhesive to platelets and then hemostatically powerful von Willebrand factor is. Let's go back to TTP now. The link between TTP and von Willebrand factor was done for the very first time in 1982 by Joel Moak and collaborators. Moak had the idea to compare the multimeric distribution of plasma von Willebrand factor between a healthy subject and a TTP patient. And that is how he observed that the TTP patient abnormally exhibited ultra-large multimers of von Willebrand factor in plasma. For the very first time, the presence of ultra-large and hyperadhesive von Willebrand factor multimers was suggested to be a key actor in TTP pathophysiology. 3 years later, in 1985, Zeta and collaborators made a step forward by showing that von Willebrand factor, but not fibrinogen, was the most strongly present protein within the platelet microthrombi, occluding the microvessels of organs obtained from necropsy analysis of TTP patient. A major step forward was done about 10 years later in 1996, when for the very first time, a metalloprotease specifically cleaving von Willebrand factor was purified from human plasma by two independent groups, the Swiss group of Felden and Lemle, and the American group of Tsai. The specific von Willebrand factor cleaving protease is obviously active when von Willebrand factor is released in blood from the endothelial cells, and this explains the physiological loss of the ultra-large von Willebrand factor multimers in normal plasma. Since 1996, where von Willebrand factor cleaving protease was first purified from plasma, several crucial steps have been crossed. In 2001, its gene cloning and its structure characterization allowed to identify von Willebrand factor cleaving protease, the 13th member of the ADAMTS family, which means a disintegrin and metalloprotease with thrombospondin type 1 repeats. In 20 years, many fundamental studies have been devoted to better elucidate ADAMTS13's structure and function, especially its interaction with von Willebrand factor. In 2014 and 2015, very interestingly, several groups from Belgium, the Netherlands, and the US identified that ADAMTS13 conformation was not unique, but in contrast, could change either in physiologic or in pathologic conditions. ADAMTS13 is a member of a family of about 20 proteins characterized by a high degree of sequence homology. The structure of ADAMTS13 is specific because it is the only ADAMTS protein to have such a short propeptide at the N-terminal part and to contain two cap domains at the C-terminal part. The function of ADAMTS13 is also very specific, as it specifically cleaves von Willebrand factor and only von Willebrand factor, and it has no other known function so far. ADAMTS13 is synthesized by the idle cells of the liver and by the endothelial cells. Its gene is located on chromosome 9, and its plasma concentration is about 1 microgram per ml, and its half-life is about 3 days. It is a monomeric glycoprotein with several specific domains, and it has only one known substrate, which is von Willebrand factor. ADAMTS13 specifically cleaves von Willebrand factor to regulate its multimer distribution and consequently its hemostatic power in plasma. We will go back in a few slides to the only human disease it is related to, the TTP. The interaction between ADAMTS13 and von Willebrand factor proceeds in several steps. The native conformation of ADAMTS13 is closed by a self-interaction between its cap domains and its spessor domain, the latter being cryptic. In a first step, the cap domains of ADAMTS13 bind to the C-terminal part of von Willebrand factor, which induces an opening of ADAMTS13 and exposes its spessor domain and its other N-terminal domains like the cysteine-rich, the first TSP1, the disintegrin, and the metalloprotease domains. In a second step, these domains are thus able to bind to the A2 domain of von Willebrand factor and thus to stabilize the binding of ADAMTS13 to the unfolded von Willebrand factor. In a third step, the metalloprotease domain of ADAMTS13 cleaves one specific bond located within the A2 domain of von Willebrand factor. This slide is just to focus on the specific peptide bond of fulminant factor cleaved by ADAMTS13 with the old nomenclature of fulminant factor amino acids on the top and the new one on the bottom, as you may find both in the literature. Also of note, this fragment of 73 amino acid of fulminant factor containing the cleavage site is a minimum substrate necessary to be cleaved by ADAMTS13 in vitro. To summarize, this is a cartoon representing the sequence of fulminant factor-dependent platelet adhesion, rolling, activation, recruitment, and aggregation after a vascular injury. Once the injury is fixed and the endothelial cells are present again, the function of ADAMTS13 is to cleave the multimers of fulminant factor to progressively dissolve the platelet clump and to prevent the thrombus formation. After this historical background devoted to the discovery of ADAMTS13 20 years ago, let's see now why ADAMTS13 is a cornerstone of TTP pathophysiology. In parallel to the identification of ADAMTS13 on the left, clinical studies on the right have been running since 1997 to prove the causal role of ADAMTS13 in TTP. The first case reporting a severe deficiency of ADAMTS13 in a TTP patient was published in 1997 by the Swiss group of Holland and Lemley. 1 year later, the two Princeps studies led on a large number of patients and showing that TTP was linked to a severe deficiency of ADAMTS13 were published by the same Swiss group and the American group of TAI. During 20 years, many studies led by several groups worldwide confirmed the causal role of ADAMTS13 severe deficiency in TTP. Recently, in 2018, a step forward was done showing that, in addition to a severe deficiency, an open conformation of ADAMTS13 was a hallmark of TTP. So finally, how does ADAMTS13 act to induce TTP? In physiology, the ultra-large multimers of fulminant factor secreted by the endothelial cells are cleaved by ADAMTS13 in smaller multimers, which hemostatic power is good enough to prevent bleeding, but not too strong in order to prevent thrombosis. In a TTP, ADAMTS13 is severely deficient, so some ultra-large multimers of fulminant factor are abnormally present in blood. Because these multimers have a too strong hemostatic power, they spontaneously bind to platelets and they form platelet-rich microthrombi within the microvessels where fulminant factor is enfolded by the high shear stress of blood flow. These microthrombi of the microcirculation induce the mechanical hemolytic anemia because the red cells are broken in the flow, as witnessed the schistocytes on the blood smear, the severe consumption thrombocytopenia, and of course, a systemic tissue ischemia. Finally, most of the pathophysiology of TTP may be explained by the following sequence that summarizes the cartoon I just showed in my previous slide. The next question now is what causes ADAMTS13 severe deficiency in TTP? The answer is well known now. In the large majority of cases represented in blue, 80% exactly, ADAMTS13 severe deficiency is due to anti-ADAMTS13 antibodies, which are either inhibitory or induce an accelerated clearance of ADAMTS13 or both. In other words, we know now that TTP is mostly an autoimmune hematologic disorder. In very rare cases represented in red, about 5%, ADAMTS13 severe deficiency is due to biallelic recessive mutations of ADAMTS13 gene. In this case, TTP is genetically inherited and called Upshaw-Schulman syndrome. In about 50% of cases represented in green, ADAMTS13 severe deficiency is due to other mechanisms like a lack of synthesis, an excessive degradation, or a non-immune inhibition of ADAMTS13. In these cases, TTP is acquired but non-autoimmune and very often associated with another clinical background like cancer, organ transplantation, severe sepsis, and so on. In terms of epidemiology, TTP is a rare disease with a prevalence worldwide of 10 to 20 cases per million people and an annual incidence of about 2 new cases per million people. Interestingly, as a function of the mechanism of ADAMTS13 severe deficiency, the epidemiology of TTP is different. Immune TTP is almost and mostly an adult onset disease with a feminine predominance. Acquired non-immune TTP is also an adult onset disease, but with no sex predominance and the presence of older patients' comorbidities. Congenital TTP has 2 peaks of frequency during childhood and in childbearing age women during pregnancy. The autoantibodies to ADAMTS13 are polyclonal. Their epitope mapping shows that they are mostly, but not exclusively, directed to the cysteine-rich and the spacer domain of ADAMTS13. Their mechanism of action is either inhibition of ADAMTS13 catalytic activity or a complexation to ADAMTS13, enhancing its clearance, or both. Interestingly, the most recent discovery concerning ADAMTS13 is TTP is that an open conformation is a hallmark of TTP. Today, we still do not know how to explain this observation. One hypothesis could be that a first trigger opens ADAMTS13. This initial trigger could be either a first wave of autoantibodies, an infectious agent, a prolonged physiologic process when ADAMTS13 binds to von Willebrand factor, or something else. Whatever the first trigger, the opening of ADAMTS13 induces the exposure of some cryptic sites, especially the spacer domain. This exposure likely induces the production of a second wave of autoantibodies directed to the cryptic sites of ADAMTS13. The binding of these autoantibodies to ADAMTS13 may maintain an open conformation together with an inhibition and accelerated clearance of ADAMTS13. If we consider now the congenital TTP, you can see here all the mutations of ADAMTS13 gene found in child-onset Upshaw-Schulman syndrome. Obviously, there is no hotspot of mutations, but they are spread all over the gene. ADAMTS13 gene sequence variations in adult-onset Upshaw-Schulman syndrome are different from those observed in child-onset Upshaw-Schulman syndrome. ADAMTS13 gene mutations do not overlap between child-onset and adult-onset Upshaw-Schulman syndrome. Also, interestingly, there is one hotspot in adult-onset Upshaw-Schulman syndrome as one mutation, the arginine 1060 tryptophan, is found with a high frequency, but surprisingly only in Caucasian patients, but not in Asian patients. In addition to the position of ADAMTS13 as a causing factor for TTP, we also know that there are some risk factors for TTP, like the female gender, the Black ethnicity, the HLA-DR-B111 phenotype, or obesity. Some triggering factors consisting in conditions increasing von Willebrand factor levels, like inflammation, infections, or pregnancy, are also well established in TTP. The better understanding of TTP pathophysiology has led to consider a more pathophysiology-based classifications of TMAs. On the left, the 3 forms of TTP are related to miscellaneous mechanism for ADAMTS13 severe deficiency. On the right, the hemolytic and uremic syndrome, or HUS, are either Shiga toxin related or complement related for atypical HUS. However, other TMAs related neither to ADAMTS13 nor to the complement system do exist, and they are mostly associated with HIV, connectivities, drugs, cancers, the HELLP syndrome, malignant hypertension, or the catastrophic antiphospholipid syndrome. Finally, beyond TTP pathophysiology, I will give some perspective on how ADAMTS13 has become not only a definition criteria for TTP, but also a diagnostic and monitoring tool and a therapeutic target. TTP initial definition included clinical criteria as a concept of a life-threatening TMA, including mechanical, hemolytic anemia, athevous thrombocytopenia, and multivisceral ischemia. For more than 5 years now, the severe deficiency of ADAMTS13 has been included within TTP definition, and it is consequently mandatory to make a definitive diagnosis of TTP. Not only it is a unique, sensitive, and specific biological marker for TTP, but it is the only way to distinguish it from other TMAs. So ADAMTS13 is a crucial diagnostic tool for TTP, and this is a simplified flowchart to identify TTP forms. In front of a clinical picture of TMA, ADAMTS13 activity is definitely the first line assay to be done. If it is lower than 10%, the diagnosis of acute TTP is confirmed, and the detection and titration of ADAMTS13 IgGs are then the second line assay to be done. If ADAMTS13 IgGs are positive, the diagnosis of autoimmune TTP can be done as soon as this acute episode. In contrast, if ADAMTS13 IgGs are negative, only the follow-up in remission of both parameters will lead either to the diagnosis of acquired TTP, if ADAMTS13 activity increases higher than 10%, or to the diagnosis of congenital TTP, if ADAMTS13 biallelic mutations are identified because both ADAMTS13 activity and IgGs remain undetectable during remission. Interestingly, the last few years have shown that ADAMTS13 could also be useful beyond acute TTP diagnosis. Today, during an acute TTP episode, even if there are no control data available to tailor caplacizumab treatment according to ADAMTS13 monitoring, we can wonder if a 20% threshold of ADAMTS13 activity reached 1 week after stopping plasma exchange could be a criteria to stop caplacizumab. During clinical remission, it is now well established that ADAMTS13 monitoring is useful to predict relapses and then to prescribe preemptive rituximab. Finally, when considering all the therapeutic targets in TTP, consisting in ADAMTS13 itself, anti-ADAMTS13 antibodies, and von Willebrand factor, today, several current trials are devoted to the recently developed recombinant ADAMTS13 that would be an alternative to the current plasma exchange providing exogenous plasma ADAMTS13 to TTP patients. Just keep in mind that all these targets are certainly not exclusive, but in contrast, are complementary to optimize the treatment of TTP patients. I thank you for your attention, and I want to thank my team from Lariboisière Hospital in Paris, all the members of the French Reference Center for TMAs, and of course, EuroBloodNet for inviting me to this TTP course. Thank you.
Thank you very much, Professor Veyradier, for this great presentation. And now, yes, I encourage the audience to ask questions in the chat.
So one question could be, do you think that an open confirmation of ADAMTS13 could be used as an earlier marker, prognostic markers in ADAMTS13 activity to detect TTP relapses? Yes, I do believe that ADAMTS13 confirmation has a great future in terms of marker of TTP diagnosis, but also to detect earlier what we call biologic relapse. And then probably it will be very helpful before the apparition of antibodies and the indetectable activity of ADAMTS13, probably to prescribe preemptive rituximab. So yes, the answer to this question is definitely yes for me. I have a second question. What about the complement measurement in the diagnosis of TTP? Yes, that's an interesting question. The complement measurement is usually performed when we have a TMA suspicion, but actually in TTP, it's not really useful. The complement measurement is more useful to better support HUS, hemolytic anuremic syndrome diagnosis. So in TTP, the complement is not really useful in itself, but it is usually done anyway because of the investigation of the TMA and to make a differential diagnosis with HUS. So I have another question. So the reference method for ADAMTS13 activity measurement remains FRETS VWF73 assay. Yes, that's true. But what do you think about the recently developed automatic chemiluminescent assay? Yes, I think it's an interesting question, especially in 2021, because this assay has been evaluated by several teams, and our team has also evaluated this assay. So it seems to be very accurate, very relevant. Of course, all the teams worldwide have identified some small discrepancies with a reference method, but it's usually the case with any evaluation. My opinion is that it's a very interesting assay. It's the first automated assay. It's very reliable. And the only drawback so far is its price, which remains very expensive. But I guess it will be a very interesting automated biologic assay for the future, indeed. Okay, so if you have someone with, so I have another question. So if you have someone with acquired TTP, what is the best modality of treatment? Just replace ADAMTS13. As I showed you, but I think there will be so I have some more questions. Yes, you mean an acquired TTP which is not autoimmune. Okay. I think as a first step, plasma exchange are definitely necessary. And whatever the acquired TTP is, if it's autoimmune or not autoimmune, and in emergency, you cannot know it anyway. So plasma exchange remains today the first line treatment. As a function of the teams, as a function of the drugs available, you may add some immunomodulators like rituximab or the anti-von factor caplacizumab. But anyway, keep in mind that the first line treatment today remains plasma exchange, definitely in emergency. So I have another question. So what's your opinion? Oh, it went too fast. I thought it was what's your opinion about the plasmic score? I think the plasmic score is very useful, especially in emergency when you don't have the result of ADAMTS13 activity. And the French score developed by my colleague Paul Copeau is also very useful. These scores are pretty similar, even if they are not exactly the same, but they are very useful, especially in emergency before to get the ADAMTS13 result that confirms the diagnosis of TTP. So I have another question. To your knowledge, are available laboratory kits to distinguish the various types of anti-ADAMTS13 antibodies directed to what the various epitopes of ADAMTS13 is? No. Today, there is no commercial assay to investigate ADAMTS13 antibodies, which are able to make the difference between one epitope or another. The commercial assays for ADAMTS13 IgGs just detect the physical presence of IgGs, and the functional assays just detect the inhibitory effect of the antibody, but they are not able to identify the epitopes on ADAMTS13. How do you speculate on the 20% threshold of ADAMTS13 activity to potentially monitor caplacizumab treatment in the future? Yeah, I think it's a very interesting question too. Again, today, there are no data to tailor this hypothesis. But as you know, for the moment, the caplacizumab treatment is given for 1 month and sometimes longer as a function of the clinical evolution of the patient. So I know that today several studies are running to try to determine a threshold of ADAMTS13 activity during the monitoring when the patient receives caplacizumab to see actually to better identify when caplacizumab can be stopped. The idea is that maybe a 20% ADAMTS13 activity is enough to prevent a relapse or a refractory phase of TTP, and then it would be enough to stop caplacizumab. But we are not sure at all of it, so it has to be determined. The threshold is more useful to determine when caplacizumab can be stopped. What I mean is that maybe it could be stopped earlier than 1 month. On the contrary, the threshold is not done to determine, to say, okay, so if we do not reach 20%, then we should not stop caplacizumab. That's not what it means, because you cannot let a patient on caplacizumab forever, of course. So again, potentially this 20% threshold could be useful to stop earlier caplacizumab. But I repeat again and again that today there are no data, definitive data, that confirm that this threshold is useful. The studies are running. Did you measure ADAMTS13 activity in COVID-19 patients? Of course we did, like everybody worldwide, I guess. Actually, what we observed in our group, and I think it's pretty the same in other groups, ADAMTS13 activity is either normal or a little bit decreased in COVID-19 patients. But obviously, even if thrombosis are observed in COVID-19 and also thrombosis of some microvessels, especially in the pulmonary circulation, I do not think that, it's my personal opinion, I do not think that the axis von Willebrand factor and ADAMTS13 is a major actor explaining the pathophysiology of thrombosis in COVID-19 patients. So, but also further studies are running, and I think it's a little bit early to answer definitely to this question. Yes, could you please comment on ADAMTS13 monitoring follow-up after recovery from acute episode? Yes, what I can tell you is that what we're doing in France, in the French group, usually during the first year after an acute episode, we monitor ADAMTS13 every 3 months, the first year. And then if the patient is really okay, the second year is every 6 months, and after that, once a year. Of course, it's provided the patient is perfectly well and does not make any relapse. If ADAMTS13 activity decreases, or if the patient doesn't feel well, of course, we will do the monitoring more often. So it's a little bit, the story is a little bit individual as a function of the patient's story. But if everything is okay, the frequency is once per trimester the first year, and then once per semester the second year. Sorry, I just need to try because I cannot see the beginning of the question. Okay, how can we identify non-immune acquired TTP about deficient synthesis or excessive degradation? Actually, it's very difficult. You cannot do it in routine practice. It's only in research when you can try to document and to investigate some cases using Western blot, for example, of ADAMTS13 to see if there is a degradation problem. But in terms of synthesis, for example, you can also measure ADAMTS13 antigen, and it may be helpful to try to document the mechanism, but actually in routine practice, it's almost impossible. It's just speculation once you have documented that it's definitely not autoimmune. We recently observed a patient with COVID with a TMA having a normal ADAMTS13 activity, but with anti-ADAMTS13 antibodies. What do you think about this case? It depends actually on the level. If it was really normal ADAMTS13 activity, I would like to know what titer of antibodies you observed, because usually you don't have high levels and relevant anti-ADAMTS13 antibodies when the activity is normal. So I don't know exactly how to analyze this anti-ADAMTS13 antibodies that you observed during COVID. Maybe they were not specific if ADAMTS13 activity was normal. Okay, another question. How long do you keep steroids once recovery is achieved? Do you give more than 4 doses of rituximab? So I think I'm not the perfect person to answer this question. What I suggest is you ask this question to my colleague, Professor Paul Copeau, during a next webinar, because it really depends on patients, actually. There's not a method for everybody. It depends on patients. In some patients, we do only 4 doses of rituximab. In some other patients, we do more. In some patients, we keep steroids longer. So I think, unfortunately, I cannot make a unique answer to these questions. It's a little bit more complicated than that. So, what about? Oh, yes. You mean the level of ADAMTS13? I think I have the follow-up of the previous question. So ADAMTS13 was, anti-ADAMTS13 antibodies were 42 with a threshold of 12. Yes. In my opinion, in the COVID patients, I think, in my opinion, it's not a very high titer of anti-ADAMTS13 antibodies. So in my opinion, it's probably not specific, not relevant, as long as ADAMTS13 activity was normal. I think it's not a relevant titer.
So I think this is the end of the Q&A session.